வேற ஒன்று அப்போ ஆஃப் ஆயிருந்தது வேற நான் சொல்லணும். நான் எது பண்றது எல்லாரும் கம்முன்னு இருக்காங்கல்ல, நீங்க கம்முன்னு இருங்க. சார் லைவ் போயிடுச்சு. Ready? Yes, sir. At the Dr. Noor, just confirm the telecast link, check it. I request all of you prayer. Thank you. God bless us all. Have a seat. Now I request our Professor Dr. Dinesh to welcome our today's speaker, Dr. Bala. Please, okay, please come. Dr. Mahapatra, you are there? Yeah. I request Dr. Mahapatra, welcome. Um, Thank you, Dr. Dinesh. Dr. Mahapatra. Now I request our chief guest and the speaker of the day, and also Dr. Mohapatra Dinesh to light the lamp on a resident can also join. Priya, you can join. Shriram, any one of you can join. Okay. Thank you. So this is the our uh, ongoing series of guest lectures and CMEs, which was initiated by Dr. Mahapatra. And almost every month, we try to invite the plastic surgeons here, guide our residents and their experience to definitely help them in the field of residency and the exam. So, uh, this time, there is a recent guidelines have been released. So, not that the scaffold is a new thing, it is now in practice. Like in our department, regenerative care was started in 2012. So, with anti. So, when you start something, we need to know are we on the right path or not. So, we take the help of guidelines. So, today we will be covering one of the aspects that in case you feel that you have to use scaffold. I know more BTM Integra, but do you know exactly why you are using that, when you should use, why you should use? So those questions will be answered evidence based, not our evidence based. So we'll be covering that day, and of course, as you know, the collagen and the nanotechnology both are important. Collagen helps in the another regeneration and nano nano and the third problem is very risky problem because most of the plastic surgeons are treating obesity for body contouring. But have you ever plastic surgery dealing with the sarcopenia? The thought and more impacts how it affects output the recovery or surgical complications. Sarcopenia is directly, so there are groups of articles now on sarcopenia or plastic surgery to understand. So this is a new update. We thought of sharing, and more so when there is a thesis of going on. So thesis of a going on sarcopenia, and most of us we were not aware. So I thought, let us see through this thesis, which is a research study. The indication may be orthopedic, indication can be gynae, but how affects the surgeon in surgery? Today we will learn. So three important part we are today covering, and let us start with the first one. How many of you are aware that what is as this society and when was it started? Most of the PGs are not even aware that at international level, in from India, that there is a society, and this society is now the today is 2025. How many years? 226. How many years? 50 years. So people are not aware of the contribution of India when it comes to wound major problem for plastic surgeon. They are not aware that there is a society called for wound. By chance, I was the one of the founder member and the founder members president. So I'm and this society has given every year one guideline which is related to. So the first guideline was the committee was formed. It's called guideline Dr. Padmalakshmi was senior and I was so they were the senior people and I was the responsibility as a man to develop and release frequently guideline for venous ulcers, radiation ulcers. These are all our cases for exam. All these are cases for exam on what doing your plan of management. So when we say EP guideline for ulcer, or we say AJC guideline for cancer, what about the so nephrotic ulcer? And now we have released in December, just 1 month before, the guideline for scaffold because this is also one of common applications used by plastic while managing the different kind of wounds. So this is for the awareness of people who joins courses and they are not aware what is it. So if the guideline for application, you put this guideline which has two part one and part two. So the part one basically first about all details about the generatives what it is application, not indication, application. So with this background of the society as well as number of guidelines to make it, so you can see necrosis is a common problem. Lymphedema is a common problem. Diabetic venous ulcer, nephrotic ulcer. Whenever you have to have some kind of guideline, and it is not made by one person. It is made by an this is index journal. It is our society of wound care and research, and I think editor for it was given various other indexing. No, no, I will also do. No, no. Oh, it, there is no published index journal. No, no, you don't know. So, are you aware about the journal? So this journal has published choice. If you have to see, just put it and research will be so now put it in 2025, and you can see the various committee members, which is mentioned here. Dr. Pramod founded the society, and then other people, Dr. and Dr. Pradeep Jain, Dr. Shiva, they are the people of the generation. So all these people are contributing and guidelines, inputs. So this is you can go through the. So as I told you, what are the parts? In the part one, the following points. So if you part one will be very easy for you to read it after. Because it is a theory. You will be knowing the definition, you will be knowing the history. It is easy to attempt and regenerative structure. Whereas part two is what was the guideline aim of the guideline and guidelines. So this is 25 pages guideline. Can you remember 25? So we converted the guideline to pages. Or can you just otherwise any guideline? All of the acronym is very. It is the acronym. SWC. So the society name, if you remember, the guideline can also be remembered. Is it difficult? All these guidelines are based on the same acronym. So the student are be able to use it. So as I will tell you, critical part of guideline. So whenever you read EPUP and EPUP guideline, it has this general part and over the year, how changes have occurred right from tissue skills, and now nano stem cells and bio. These are the contribution by making the regenerative. We will go through the more details. So here it is. So here I am of these guidelines and easy for us to remember. If we are and very easy to remember because we are categorizing into category and the exam and and many layer and what is the application. So broadly, and acellular can be single layer or bi easy to remember in the exam. Classification divided and A is divided into single layer, bi-layer, or the there is cellular. Okay, cellular. Come back fast because this question is coming in your exam. Right time you disappeared. I am teaching the class so that they should be able. Yeah. Very fast. So how you classify the regenerative scaffold? Acellular and cellular. Acellular can be single layer or bi-layer. And bi-layer are there. Next mechanism of action. So the first mechanism is physical and physical and how it works. I not as it is not a particular cellular activity breathing. So this breathing and three mechanisms. This is one mechanism. What mechanism? What is mechanism? And function is possible on balance the response. Finally, nanotechnology. So today, I and nano improving of the cell adhesion, proliferation, and active release. What will release actively? Nanocellular. You don't have to copy yourself. You listen, you try to understand. But okay, data will record to the return certificate. Time is saved. No problem. But I am telling you, the mechanisms are physical, molecular, cellular, functional, nanotechnology enhanced. What are the implications? or large area of the tissue is lost or damaged, and we can provide so much large skin. It is the full thickness. Partial thickness will heal, healing when it comes to full thickness is branded or excised. Now it needs a cover. So this scaffold will help as a not substitute only fully cover. And what it will help? It will restore the thermal architecture and also just one, we want not only it should heal, also get is it clear? And of course there is another number which is also non-healing of its vein, protein, all those would what it will do in the chronic, it will reverse. That is the matter. It is inflammation. How it will reverse the healing time. So mechanism of action. Now what is the advantage over a scaffold is also a cover, dressing is also a cover. But if that dressing is regenerative in nature, then it is a scaffold. Regenerative scaffold. Otherwise, simply gauze or paraffin gauze or foam gauze, it is simply a cover. It doesn't allow for the wound to regenerate. It just gives the healing. So we need not only the cover, we want regeneration also. Otherwise, your cover will be fast. Within 3 weeks, wound will go to the non-healing phase. 3 weeks only. Even the donor site, even the donor site is not healing, it is becoming non-healing because of the hydrogenic. You have created that. Of course, healing will be superior and functional outcome by preventing contact by the rate. Both will be fast. The rate of healing will be faster. If you are 1 days, let it be a 50 days, 12 days, we don't know. The craft you have harvested or the wound of the creativity and even one to the include one how because it is creating the like molecule and it just cover carbon change. If you want to change the microenvironment, then you have to mimic like a cover in cover. It's a cover. Other advantage, both biodegradability and mechanical integrity. Each word carries a meaning and reasoning. Is it clear? Of course, anything you do, whether surgery or any application, and the word when you use limitation, cost. It's a limitation to something. Cost. EMI, you are ready to pay. If you pay, then sometimes you will give it. So, paying a one and get out of the problem. So that is why I have not written the cost as the limitation. It should not be as just no meaning. Why you can be zero profit, you pay, then only it is a cost. You make your own, you know, problem is limitation of material and fabrication challenges. And why? Because if you use very thin, there is a rapid degradation, correct? And if you use thick, it is unnecessary use, cost increases, and that there will be different. Same person is saying, I am well, and there will be very. This is a problem. Standardization has to be correct. And the product is or my material is more giving salary. And this is if this is not controlled, there will be uncontrolled or worst growth factor release. Too much of bioactivation will cause of the growth factor release. And some of them will have a very short half-life and inconsistent therapeutic effect. These are the challenges when we are selecting the scaffold. And when it comes to in vivo, the limitation is slow vascularization. Some is a challenge for us. And the final standardization. We need there are very little data. Everybody is all told the cost. Is it okay? The limitations of we have and regulation is another problem. Now FDA now they are considering it as a human cells. Suppose are regulated as a medical devices or human cells or it is cellular and tissue product SCP-PC. It is no more a simple dressing. Please don't take it as a scaffold. What is there in the scaffold? Somebody has given BTS. No, no, no. It is a very, it is a very considering it as a device now, medical device. So how you take that when it comes to the clinical translation, there is a impedance because of lack of standardization, insufficient clinical evidence, and manufacturing limitation. These are the regulatory considerations, outcome. The last is the for expediting the approvals. So recently, US legislative they are looking to access to innovative regenerative programs. So, and India innovation is the to innovate not is the hard that is and how it is possible by nano bioprinting and biomaterial. This is the future of this technology is going to be used. And another future is how to access the bioactivity bio that controlled release and like body makes people, it is a food pyramid at top. Okay? So similarly, the future is make an intelligent bioconstruct. And another, it will focus on patient specific, not one for all. It has patient specific also. Now we are coming to the part. So as I told, what is the aim? The aim of the guideline is prepare a guideline for which should be simple and practical. When you are thinking of using disability and objective, it should be able to, and that is possible when there is an problem. And of course, it has scientific evidence based, scientific and evidence based. What is the acronym? As I told you, first is the S phase, analyze the patient and wound both. You know how to of a patient of this phase, part three. Correct? So you know the patient examination is it of using scaffold, first you should do analysis and then when it comes to the analysis, you have learned the analysis, how you analyze, you know how is chemically and digitally, you- or only to software, automatically, photography. Is it difficult to remember S? Both. Scan. You can before that is ready. And for that, you have to follow the concept of ID. So the concept of is management of the implementation and and actualization. How you do? You know what is remove, what is align, cover. You will manage your your- you know what you do. It is like a motor. You do this daily. You can this the form of the or from the fan autologous or from a and if you follow, one day wound will be in the heat or wound will become ready for cover. When it comes to the cover, before you cover it, you have to take a decision that in case I have to choose a scaffold to cover temporarily or I have to use for using for class, then I have to manage with the scaffold. Then you have to choose how you will choose whether the whether it is a dermal system or epidermal system or dermal epidermal system of the substitute, and it is what are the common products. So can you see integral, BTM, all this mentioned, or you make your own scaffold. So clinical decision you have taken. Now further, finally you have to repair, reconstruct, and how you know better off because it has vital tools to affect regional macro. Right? Remember the guideline? Yes, CR and during rehabilitation, you must report follow residency and religious code. Religion has they say don't use faith, clear. So if somebody asks you say yes, in one slide all 25 pages covered. So it is remember same acronym is used for diabetic advertising fasciitis or even a dressing or a radiation ulcer. So this slide will give you and the patient is in your follow the SWCR. Otherwise, you keep reading books and articles, and finally, you Is it clear? So part two, JIPMER. I have given you the details. This is given in the actual article. You have to go and and we have been using for as simple as our or for region or for bone and finally for repair and reconstruction. These are the indications which doing. And we are taking our these are the two layers. These are the three layers. And this is the four layer. Combination. Like you know, no integral and increase bonus. If you put three layer, you add and so your both one is wine or whatever, and inner is the allo. So you can make a auto allo xeno synthetic combinations. All this we have been using. And you say, sir must be telling lies. So then I have to prove it. So single layer is the as simple as I'm not even. So you go to the label and apply over the wound. It's called regenerative scaffold, allograft, human allograft. Really our yeah, labor room for one patient or a wound is amnion. So why is our cow skin and the human issue is available and we can use it. Regeneration will start. Is it okay? And you don't believe? Our residents have published also. Not one, many. This is the example. Amrita, Amrita is here. And now comes so, yeah, throw egg in your family. Peel it, bring it, wash it. In small areas. You need 100 eggs to make a large. But for small areas, you can always use it. These are our reported cases on egg. Then collagen. What is the source of collagen? Cow, pig, or fish. That is, or let's see, it can be or non, it can be powder, the powder. So this is a source of these single layer. And these are the applications. shared by all residents are writing. These are the various examples. Single layer only. And now comes the allograph. Now allograph means you can take only from placenta. You can take from relative. This is also damage. So this is a these are the examples of the relatives or from the dead bodies. So it is a cadaveric. Can you see? Cadaveric graph. When we did an bilateral cadaveric hand transplantation. So non-healing. So first he should have survived. Then only they should be the transplantation. And second, bulla. Bulla is epidemic. Now, auto. So you just take by this time of you immediately negative and raise it and take and apply. Can you see that the syringe bulla is found? It looks like a bird, na? Bird bulla. Then what you can do? You can take the epidural and you know, and it will come lot of tissue. Some graph is also like that. You can mix the some lymphocytes into the APRP also. I will spray it. This is Padmalakshmi. Document. And how many cases? One, two, three, some six, seven cases. And for another sources, Kukum still. I forgot to tell. No silk worm. Silk is another source. Don't get started. Anything done and two layer. What is and what is xenogram? Another one. Another one. Another one. Can you see? This is prepared cell. You have taken collagen, multiple layer of, and it is indigenously prepared. So integral is collagen. Collagen. Glue two layer, two layer. Yeah. You know the says here it is free. But can you see? This is silicon sheet. Those white are silicon sheet. And the collagen is fixed on the silicon sheet. And so you apply it. See, you see silicons and collagen sheets are fixed on the silicon sheet. And you make a scaffold. Leave it for 2 years. Really, you burden spending a day. This is the silicon plus collagen application. And another one is not silicon, collagen outer, pixel graph inside. Can you see this pixel graph? They are minced into pieces. They are and they are applied. Large area of the book is also by this is very good. Now in outer layer is polyurethane and inner layer of two matrix BTM. Now this is covered. We did not find but we use free of cost. It was published in the medical journal. So there is electrical after full excision regulation. Another case where it was used by Dr. Padmalakshmi as a faculty here on the school it was published in IJPS checklist. Now another polyurethane so this is application. You know ना when tone nail aversion आता है regeneration are 2 years. And if you don't use regenerative type of cover, you crooked nail, fungal infection, badly, isn't it? So I apply the regenerative BTM and suture it like a template over the and only so like a you apply the BTM. There is out silicon three layer. Three layer is outer silicon bonds. Actually, it is bilayered, but written three layer. It was written biosilk bilayered. Now, three layer can be another combination. Outer silicon, collagen, then when another indication is burn wound. Bilaminar, another three layer. You see the combination on the top. Outer silicon, then collagen, then non-keratinocyte, non-keratinocyte don't have to they are the regeneration and healing because she has done so many. She's feeling our results are regularly doing, except newly joined. If they show interest, otherwise, core layer is there. The outer layer is silicon. Second layer is collagen. Everything we are keeping. If they want, they can see other. These things are there. Study folder also. Team membrane. Can you see this whitish endotic membrane? So became three layer. Nobody has protein. These are the characteristics. Can you see the taste? They are mixed. Yes. Is it clear? Food layer. Actually, we have videos made. Okay, 1 hour, 1:15 to. Is it okay? So now we will go to talk. Our speaker is Dr. Gokul Balaji. Welcome, Dr. Balaji. I would like to introduce him. I introduce him. Everybody can see. MBBS and research. Everybody can see. And how many courses he has done, from where he has done, or how long he has done. Everything I have, you read yourself. Fellowship also done. Vast experience. And various posts he has held. Any our resident can work with him and learn the tricks of the trade. I know about him. He is, he is left. This much you have to learn. All varieties. And the last is the treatment of which is a botox plus medicine, chemical PRP, all we are doing here. In government free because of anti. We have doing all chemical we have everything we are doing. So we are practicing. This is not complaining. And various works are as a and his interest is endovenous laser. He is telling me. He is giving Mauritius also. Life goal is very good. To be a better human being. Yesterday, serve the humanity to my conscience, earn money ethically. That is very important. new residents. So the topic which we will be speaking is the new upcoming technology. That is when uh, collision with nano crystalline. This is the first time in the country it is being launched. Fitting technology. Till now, you must be knowing we were collagen with silver. Jet, jet, silver also we will be using. But this is the first institution and government who have started using it. It is recently launched technology. How many knows that? Use it. Similarly, Bala also can use. So we have latest. So, sir, over to you. Venu or so, sir has given a pen drive. Huh? Yes, sir. Open. So this you minimize. Where is it? Minimize. Minimize. And we will start from back. Now open. So,
Good morning. Today I'm going to present about how to harness the collagen biology with the nanocrystalline silver for superior wound outcomes. So, as I told, wound healing is still a problem. So, why does it fail? Uh, Basically, it remains a global surgical burden till now, and infection. Infection is the main problem in wounds, and dysregulated collagen. These two are the main problem for the delayed wound healing. So previously, Sir has explained in detail, like dressings nowadays has to be is more advanced based on their bioactive interfaces rather than just protective dressings. Nowadays, we are using bioactive interfaces. So, what is a bioactive interface? So, these are advanced dressing materials that actively interact with bone bed. So, they either deliver therapeutic agents like growth factors, antimicrobials, etc., or they possess inherent properties like maintaining the moisture and maintaining the pH balance, antioxidant actions, and etc. So, instead of just giving a protective dressing like a gauze or something, now bioactive interfaces which actively interact with the wound bed. What are the functions? They regulate healing, or they manage infection, or they reduce the inflammation, or it promotes the tissue regeneration. So this combo of amoxicillin with collagen covers all of these four functions. So let's see how silver help in wound. Then we will see how collagen help in wound healing. Then we will see how the nanocrystalline silver, how different nanocrystalline silver is from routine silver. First, we'll see the action of silver. So, silver is mainly, as we all know, it has an antimicrobial action. this is the cell membrane. It binds to the bacterial cell wall proteins. It alters the cell membrane structure, causes cell leakage and death. And then it intervenes with the DNA and RNA. They binds to the nucleic acid in the DNA. They prevent the replication transcription and they halt the growth. And it inhibits the protein and the enzyme in the bacteria, and it also causes disruption in the biofilm. So by these four actions, it causes antimicrobial action, and silver has anti-inflammatory effects also. So it causes cytokine modulation and MMP regulation. MMPs are basically matrix metalloproteinases. They are high in chronic wounds, so they impede healing. So silver reduces the action of MMPs and cytokine. So it reduces the inflammation in the wound, causes healing. So wound is a collagen centric process. We'll see how collagen helps in the healing of wound. So collagen is mainly a structural backbone of healing. It is tensile strength. It acts as a scaffold for angiogenesis, and it also acts as a cellular signaling platform. And we all know there are three phases of wound healing. So the collagen helps in all the three phases of the wound healing. First, in inflammatory phase, it acts as a provisional collagen matrix. Then in proliferative phase, type 3 collagen is deposited. Collagen also helps in the fibroblast migration. And in the remodeling phase, the final phase, type 3 to type 1 collagen deposition is happening. And in the remodeling phase only, fiber realignment and cross-linking happen. So in this picture, we can see A is the normal skin process. So in B, we can see there is a discontinuity in the skin. There is a wound. So it causes neutrophils and monocytes and everything is accumulated. So on the picture C, we can see collagen 3 is deposited. And the picture D, that is the remodeling phase, collagen 1 is substituted in place of collagen 3. So the mechanism of action of collagen in wound healing. So as you saw in the picture, first injury exposes the collagen. So this exposed collagen acts as it activates the clotting cascade and brings in all the neutrophils and everything and brings in the fibrin clot. And the collagen fragments, the broken fragments also attack macrophages, and it acts as a signaling molecules. It influences the immune response. In proliferation, the scaffold, collagen acts as a scaffold for fibroblasts. And the second is the most important thing. It stimulates cell migration. So it promotes movement of fibroblasts, endothelial cells, and keratinocytes. So once the keratinocytes is migrated into the wound, it causes the cover of the skin. So the wound bed, it causes the good cover of the skin also. And angiogenesis also for we all know vessel growth is needed. And growth factor stimulation is also done by the collagen. So these four actions help in the proliferation. And how there's a remodel. The fibroblast organizes the collagen fibers into stronger fibers. So initially the collagen arranges in a haphazard way. So the haphazardly arranged collagen acts just as a cover for the wound. So in the remodeling phase, the haphazardly arranged collagen organizes into a uniform layer. The type 1 is deposited and it organizes uniform. So it reduces the hypertrophic scarring for delve and collagen goes now for by MMP, and impact fibroblast activity and bacterial biofilms also matters. So all these leads to chronic wound, weak scars, with scars with low tensile strength, and infection-prone heads. So what is an MMP? MMP is a matrix metalloproteinases. It is a family of zinc-dependent proteins. So these break down the extracellular matrix and the scaffold between cells. So we have to prevent the overaction of MMP. If it is overacting, it break down to all the extracellular matrix and scaffold. So we have to keep it in control. So in this you can see that the MMP is sitting on the collagen in the extracellular matrix. So we have to keep the overaction of MMP in control to get better wound healing. So infection is the silent saboteur of collagen. So we have to control the infection obviously. The bacterial proteases degrade the collagen. The biofilm resists host immunity, and local inflammation also inhibits collagen maturation and prolongs inflammatory state. So basically, this collagen deposition is hindered by the any inflammation or infection. So we have to keep the infection in control and to have a good collagen supportive environment. So this infection control is achieved by nanocrystalline silver. So why conventional antimicrobials fall short? Because cytotoxicity to the fibroblasts and spermatocytes. So basically, in addition to killing the microbials by the antimicrobial, it kills the host cells also. Host fibroblasts and keratinocytes also they kill. So the healing is slow. And conventional antimicrobials have narrow antimicrobial spectrum, and they have a short duration of action and have poor penetration into biofilm. So we'll see the history of silver as an antimicrobial, how silver was used from the olden days. So in ancient period, like in Greek and Roman culture, they were using silver coins or vessels to disinfect the water. In World War One time, silver leaf and were used to combat infections in ages further. Here we can see the roadmap. The use of silver started from 800 BC. They were using silver coins to disinfect the water, and in 1800 they were using silver for treating epilepsy, infection, and acne. In 1940s, wounds were packed with silver foil, and in 1960s, silver nitrate was used for burns. And 1970s, silver sulfidation cream were introduced, and in 1997, nanocrystalline silver was started, allowed resins to be in direct contact with the wound. And today we are using nanocrystalline silver all over for burn wounds, ulcers, infected wounds, etc. So now the usual silver is replaced by nanocrystalline silver. So how different is it? It maximizes the efficacy and minimizes the toxicity. How? So what is nanocrystalline silver basically? The particle size is 1 to 100 nanometers, very, very small compared to the routine. So when the particle size is small, it covers more surface area. Say for 1 gram of, I'm taking an example. If you're seeing 1 gram of silver ball, you're taking only one ball, it covers a small area. But if you are uh, you're separating, like if you are breaking it down to multiple smaller pieces, the 1 gram ball, to cover a very large surface area. So this is the basic idea of nanotechnology. So the same amount of the source material is divided into very small particles so that it will cover a larger surface area. It also it also achieves a sustained release. So sustained release is there. So instead of peak and trough, suddenly it will release high amount of silver, suddenly it will release low amount of silver. That is not happening. In nanocrystalline silver, standard sustained silver ion release is happening. So it is in a stable control antimicrobial environment and reduced peak cytotoxicity also. So there is no peak control. So the mechanism of action of nanocrystalline silver, it disrupts the bacterial cell membrane, inhibits the DNA replication, it inhibits the respiratory enzyme. The same action of silver in a better way. It is effective against gram positive and gram negative. It also acts as MRSA. So it also penetrates the extracellular polymeric matrix. It prevents biofilm reformation. It maintains low bioburden consistency, and it is crucial for chronic and complex. So the silver biology, we are using it together. How it helps? So the silver controls the infection. So basically, the infection, when it is controlled, it protects the collagen matrix, and the prolonged inflammation is also reduced, and it preserves the fibrillous viability, and it creates an optical microenvironment for the collagen synthesis. So the wound that environment is preserved so that the collagen can act better, and the collagen can help in the wound healing. So the advantages of the synergy between nano silver and collagen. A faster granulation tissue formation is achieved and improved wound bed quality, reduced time to closure, lower infection rate, lower hypertrophic scarring, and better tensile strength. So the last two are achieved by collagen. The first four, faster granulation, improved wound bed quality, these are achieved by nano. I'll present some of my cases. First case, she is a 65-year-old female. She is a known case of breast carcinoma post mastectomy. She is on immunosuppression chemotherapy. She came to the hospital with history of burns. She was doing a puja during Ayuda Puja time. She was showing camphor to the refrigerator. The refrigerator blast, and she was suffering burns to the camp. And the wound got infected. It was not fit for skin grafting at this stage. So the nano silver collagen will be prepared in the wound bed for grafting. So the first infected wound, first discharge is there, biofilm is there. And second picture, after applying the nanocrystalline silver and collagen, wound bed is granulated, and now the wound bed is fit for grafting, and grafting is done. The second picture shows 2 weeks post I had 2 weeks post skin grafting. This one showing 2 months post skin grafting, and the last picture is 7 months post SSG. So from this wound, the first discharge, the wound bed is prepared, and after skin grafting, we have achieved a considerable decent outcome. And the good thing is, we can see the graft pinchability is also there. It mostly some are normal skin. There is no hypertrophic scarring, or there is no keloid. It mimics the normal skin. Case 2, 44-year-old female. She came with a history of snake bite. She developed necrotizing fasciitis. It's a viper snake. From outside, it looked very small area was involved, but when we went inside, the full it went till the knee region. So it was managed with debridement and negative pressure wound therapy, and skin grafting was done. But the spotty raw areas were there. So this is after skin grafting, everything was done. Uh, spotty raw area was not healing; it was bothering on and off. So this put her into more procedures. So we applied nanocrystalline silver with collagen. 20 days post application, the spotty raw areas was covered. So before it applied, the spotty raw areas was not healing. We can see it was glowing inside. It was eating the grass. Once we applied, it started healing. Case 3. The next 3 cases, they came regular on a Diwali day. The same cracker burst. They are a family. So the next 3 cases, we have managed with wound debridement, and collagen sheet was applied. So after the collagen sheet is dried off, we gave them off with nanocrystalline silver and collagen cream, and epithelial was very good. These 3 cases. So this is the one after debridement. You can see the collagen sheet is applied. This is 2 days post op. This is 10 days post op. We can see the collagen right often came off. So I started applying nanocrystalline silver collagen. This is 2 weeks after. We cannot make out suddenly any word. Utilizations is very good. So the first case, please also learn only break collagen sheet is done. Collagen took up in 10 days. After collagen is dried, it was given. So the immediate post up after collagen sheet application. 2 days, this 10 days post up. So once the collagen is dried, I gave her nano-crystalline silver collagen cream. So 5 days. Just after 5 days, from this one, so it was totally dry. And after 2 weeks, it is quite decent. Okay. So this is the one, it was the bridal. Collagen sheet was given. This 10 days post collagen sheet application. The collagen the non-silver cream was given. This is after 5 days. After 2 days. You can see the chin area bone but here after 2 weeks chin area everything is covered. Epithelialization is good. So since it attracts the keratinocytes, the epithelialization is better. The cases this is a 36-year-old female came with scan. All blisters in hands. All blisters were there. She was not willing for collagen sheet application. So debridement and just nanocrystalline silver collagen cream was applied. So this is after 45 days. You can see the video. Yes. So she's able to movements is really good. This one is a 20-year-old boy. Very small abrasions over the face. I gave him with nanocrystalline silver collagen. You can see the epithelialization is very good. Like much better. Anyway, the 50-year-old male is comes from he came to the hospital after 1 week. Here you can see he was not taking care of his own properly. So a lot of everything was there. So the debridement was done only as an OP procedure. So through debridement, cleaning, we gave them with clean. And we can see the proximal part of the nerve, the keratinization has started happening. So just in 4 days, it showing good results. So in my practice, how I use silver collagen, I use with giving me routinely for superficial abrasions, sutured wounds, instead of just giving neoperosin ointment or povidone iron ointment. So I am giving antimicrobial along with collagen. So it helps in faster healing of the small bones of body areas. The collagen sheet is filled out. And donor sites, SSG donor sites, we don't disturb the donor sites for 2 weeks. After it is open, we will tell them to apply, and it epithelialization is faster. So, the take-home message is collagen is the main cornerstone of wound healing. In infection disrupts the collagen biology. Of the infection to make sure collagen acts well. So the infection control is silver. Nanocrystalline silver is a much better form. So nanocrystalline silver and collagen good wound healing. So sustain collagen friendly. Thank you.
Thank you very much. Difference is not gross, the difference is nano. Because they think this is also unreal. Because they are not thinking what the technology has done the change in the silver. So that is possible only when the meta analysis is done, already testing has been done in the world. Now we are launching in India. Correct? So they will think I look all garment look same. Raiment garment also and local garment also. So by look they will look same, but they don't know the durability. They don't know the technology which was used to darn it or to make it. So this is possible only when actually you use it and you actually understand and learn. So thank you for making the difference in knowledge and the otherwise they will think very casually just because something is shown. But definitely it is not you are telling the literature says the nano is always better than the simple silver. And when it is combined with the collagen, which we know the collagen has a potential of regeneration. So not only it will make it heal and the cost of infection not allowed to increase. So both will be taken. This has been launched in the India, so very good. So with this, we will go
Yes. It make presentation.
on conservation. As I'm also sharing because recently some samples were given. Actually, they get electrical as a problem. They're not healing. Or a wound which is about to heal and now the quality of the blood scar like this is worse as better to control the healing because simply this is another area to take into account. For so that is how over the home, how you don't have to healing. So same way, so one part is applying, the other part applying API. One is so this of course it is not only uh, if Clinton has it, it is because of the only making the wound heal is not adequate. If prevent that is also important. The place and graft is got healed, got point. Reality as a reality also involved. So okay, and now the next topic is research. But because of opinion, there are many people out in topic. It is the same era of same opportunity in the plastic surgery forum in 1960. Or research. Opinion is another problem. It is direct linked with the outcome of the body into its body. So whether the and right. Because hard metal is the subject is article. There is a very much I thought this is also one of the big target effective. So we are supposed to also be that our is in then here I am highlighting why sarcopenia is important and people should be aware of. There article. Everybody is reading CRS, but nobody notices it actually come. Yes, or any because how far that complication going to be. Yeah. And clear mind is not as the Narendra. Because that which he tested. I also said even patient undergoing grafting, and when I patient had a sarcopenia, why you don't know what was there was imminent sarcopenia. The problem is patient sarcopenia. Now sarcopenia patient. Both related to like obviously any surgical procedure. No, it is a indication of like the body contains. Similarly, sarcopenia is now is another indication also and alert also. Both. So with this, we have Dr. Narendran. He is online. Also, functional outcome also patient satisfaction. I start. Here, let him share his thesis that he has tested effect of central sarcoma. What happened? Zoom, you join. Share his. Yes. He doesn't know the.
Uh, Hello?
Big crowd.
Hello. Hello, கேக்குதா? Hello.
Start.
Uh, Good afternoon, everyone. I'm Dr. Narendran from the Department of Orthopedics, here to speak about the effect of central sarcopenia on the functional outcome and patient satisfaction following TLIF surgery. So before I start, I would like to thank my professor, Dr. Chittoria, for providing me the opportunity to speak on this platform regarding my topic. Next slide, please. I would also like to thank my guide, Dr. Pasupati, who was an integral part in helping me on this paper. So let's begin with what is sarcopenia? Sarcopenia is the loss of muscle mass with increasing age, which is associated with either decreased muscle strength or decreased physical performance. In this study, we're going to be dealing with central sarcopenia, which is the same, the loss of muscle mass and strength, specifically involving the core regions of the abdomen and the trunk. Slide, please. So my aims and objectives were to compare the functional outcomes by means of ODA scores and patient satisfaction through another questionnaire known as the SSP questionnaire among patients who underwent this TLIP surgery with or without central sarcopenia. Next. So my study is an ambidextrous cohort study set in JIPMER involving patients who are operated for a multitude of indications by TLIP surgery from February 2019 to December 2024. The inclusion criteria of ours was to include patients more than 40 years of age and patients who had undergone open TLIP surgery 1 to 5 years back, and patients who will be undergoing TLIP surgery uh, from the present to the future. Exclusion criteria was we excluded patients who were treated with TLIP for tumor or infection, and those patients for whom preoperative MRI was not available, and those patients who had undergone revision surgery. Okay, next slide, please. So this is the flowchart of my study. Since this is an ambidextrous study, there is a prospective arm and a retrospective arm. So coming to the retrospective arm, we recruited patients who had undergone TLIP surgery at more than 1 year and less than 5 years back. We accessed their preoperative MRIs, and in those preoperative MRIs, we measured something known as the psoas lumbar vertebral index. So, what is this PLVA? This PLVA is a ratio calculated by keeping the cross-sectional area of the psoas muscle as the numerator and the cross-sectional area of the upper border of L4 vertebra as the denominator. And this cross-sectional measurement happens at the upper border of the L4 vertebra. So this ratio which we get that is known as PLVA. This PLVA of our patients was measured, and on arranging all the PLVA values which we got in an ascending order, we got a median. And based on the median, we divided patients into two groups. One group will be high PLVA group, the other will be the low PLVA group. And independently, in both of these groups, the functional outcome was measured by means of an ODA score, and patient satisfaction was assessed by the SSQ8 questionnaire. Next page, please. The same thing was done in the prospective arm, except that instead of recruiting patients from the past, here when patients presented to us for the first time with complaints, uh, if they required a TLIP surgery, we recruited them into the study. We measured the pre-op MRI ka PLVA values at the time of presentation and the preoperative ODS scores at the time of presentation. Then we waited for 1 year. At 1 year post-op, we again assessed the patient, and whatever post-operative evaluation had to be done, that we did, including the ODA score and the SST weight score at least 1 year post-op. Yes, thank you. Next slide, please. So the investigations and assessment, the tools which we use for assessing, these are the main tools. One is the MRA, the investigation, which was done as part of protocol for any TLIS patient, and total psoas muscle cross-sectional area and psoas lumbar vertebral index. Next, please. This is an example. So in this, you can see I have clearly delineated the L4 vertebra cross section and the individual cross sections of the psoas muscles of the right and left sides. So what we did was we summed up the psoas muscle area values of right and left side, and that we kept as the numerator. In the denominator, the cross sectional area of the lumbar vertebra at the corresponding level, that was kept. So in the left, we can see that patient has with the naked eye, we can't say if the patient has sarcopenia or not. But judging by the film, we can see that the psoas muscle area is very less for the patient to the left. In contrast, the patient to the right has a good psoas muscle bulk. So we can assume that for a patient with sarcopenia, the MRI picture would look like something like how it is portrayed on the left, and the opposite for patients without sarcopenia to the right. Next slide, please. So, like I said, the median value was calculated for the whole group and also for male and female patients separately. Based on the median value, the patients were grouped as those with less PLVA and those with high PLVA, group 1 and group 2. Next slide, please. Analysis of PLVA with SSQH scores. I used the unpaired t-test for this analysis. On analysis, what we found was that uh, the central sarcopenia, whether it was there or not, did not have a significant effect on the patient satisfaction following TLIP surgery. And if you go to the next slide, you would see that the central sarcopenia did not have a significant effect on the functional outcomes also following TLIP surgery. Among the 40 patients whom I analyzed, this is what we arrived upon as a result. Next slide, please. You can skip this slide also. Yeah, so discussion part, the thing is, in today's scientific community, there's not much literature about the effect of sarcopenia on functional outcomes and patient satisfaction following TLIP surgery. I have listed two studies which I felt were close to my study with regards to the core of the topic. In these two topics, they have discussed a little about sarcopenia and spines. One of which it was a paper published in China. They have discussed about single segment lumbar fusion and sarcopenia. That is probably the only close study which I could find with regards to my topic. The reason I've put this up here is next slide. The reason I've put this up here is this is a very less research. This is sort of a novel topic, and this is still an ongoing study. Uh, Sample size total sample size is 128. So far, we've covered 73 patients. Of the 73 patients, we could recruit only 40 patients because the other 30, we could not recruit them due to a variety of reasons, including unavailability of MRI, incorrect contact details due to a few patients had also died. Who had operated some core previous weeks, a few patients had also died. Due to these reasons, we could not include 30 among the 70 patients whom we've screened so far. Likewise, the recruitment will still, likewise, the recruitment will continue in the future. And we assume that once we achieve the desired sample size, the results may vary. But we've got so far, it is an interim analysis. So that is one thing I wanted to comment upon. And going with the strengths of the study, like I said, it's a novel topic and it is a time efficient analysis. Sarcopenia is a chronic condition requiring years of follow. Because it is an perspective study, we are helped with the fact that we can recruit patients up to 5 years in the past. So there is no need to follow up such patients since the records, whatever records are available already, that only we're going to use for the analysis. Limitations, there is the subjective nature of the data. The pain scales, the ODI scores, the SSQH scores, whatever I've taken into account as part of my study, everything is very subjective. A lot of these patients may have very bad backs, very bad sarcopenia, but still they may be satisfied with the surgery because their metric of satisfaction may be different from what someone like maybe I would have if I had to undergo such a surgery. So there is no direct correlation between the condition of the backs of such people and satisfaction of such people and even functional outcomes. Our people are generally resilient to pain. So even in the postoperative period, even if they have not had an ideal result, they would still tolerate and continue with their routine activities with the pain. So the functional scores also have a tendency to vary. That is one limitation I wanted to highlight. And the logistical issues, which I already highlighted, such as the MRI issues, contact number issues. Next slide, please. Yeah, so coming to the conclusion part, this is an ongoing study, and the preliminary analysis of our study suggests that central sarcopenia does not have a statistically significant effect on the functional outcome or patient satisfaction following field surgery. That's all for the talk. Thank you. Any questions?
Okay. You tested the one part going particular patient. As I was also showing you in plastic surgery, patient undergoing chest reconstruction and being done by acupuncture technique. What is the relation of each pole? Some of them will have a direct link. Some of the procedure may not have the direct link. You, you are showing there is no effect. Okay? Nature patient came for the result. Patient is happy with the cough result. That cough would have been treated in 1 day, but you took 3 days. That patient was not doing. So the study shows the sarcopenia, number of hospitals stay in the higher than the normal patient. Here the is competition, whether it is a general surgeon or plastic surgeon, get alert. You be plastic surgery and you are patient for various treatments. It is classically looking like a sarcopenia. As I gave you the exact thing, how let me check it. Talk about history of this epidemia. Such patient will be happy with the nose change. Including body or the sarcopenic patient. So thank you, Dr. Narendran. And you have in one aspect of the condition of surgeries. Correct. Unmute or yes, unmute your mic. Oh.
Hello. Hello.
Any question?
Reception is very poor here, sir. Hello. Hello.
We want to thank you and when you will come, you will receive this. This is awesome. this you can receive.
Thank you, sir.
So you have been given good recognition because of the interest you have shown.
Thank you, sir.
Okay, then when you reach Telegram group and attend evening round online. Okay, you can be with us online, but mute yourself so that we will go to the next part of the session.
Okay, sir.
So now we will go to the next part of the stop sharing. Go to the our PPT. This is easy. No hurry. This exam is not time bound. Okay. So with this, with this, we have covered the three parts, and now I would like to felicitate our speaker of the day. Uh, Already Narendran I have told you, so he will come and take it. Now physically present, I request Mohapatra to felicitate him with a memento and please clap for him. One more thing is some more thing is there. Yeah. Very good. Very good. This will help you to represent the next participants. Those are those who are joining online, they will get a certificate based on their Google form field. Exam going. Salary and month or 1 month. And now, okay, all other they are in the they are what is so thank our director and sir and our speaker who accepted our invitation. Our faculty who were uh, in planning, our resident who showed our fellow line. They have contributed. With this, we are closing the session online. Physically, we have a huge photo. So thank you once again, one and all. Our faculty from Kashmir, Dr. Farooq, and he has praised your talk and other. So thank you. One and all. With this, we close the session.
But yeah, you have to stop.